So optic disc edema can be a vital manifestation of varied ocular as well as systemic disorders. Some of them are relatively benign, while others may have devastating visual and neurological consequences. Ophthalmologist may be the first person whom a patient with disc edema may consult. Thus, ophthalmologists must be aware how to differentiate among the varied etiologies based on the history and clinical features. OCT is an in vivo quantitative and objective measure that can detect, characterize, and monitor axonal swelling associated with disc edema. However, there are paucity of studies in the literature involving clinico-demographic profile and OCT characteristics of various categories of disc edema. So our purpose was to assess the various etiologies of the disc edema at our institute and to evaluate the retinal nerve fiber layer thickness in varied etiologies and to look for any possible correlation between the clinical severity of disc edema and RNFL thickness. So it was a hospital-based retrospective observational study from January to December 2019. All patients with unilateral or bilateral disc edema presenting to OPD of our institute was included. Pseudopapilledema was excluded. Demographic data and clinical history were noted for all patients. Each patient underwent comprehensive ocular examination, and disc edema was categorized according to the modified Friesen criteria and further subcategorized into mild, moderate, and severe for statistical analysis. RNFL thickness was measured by spectral domain OCT. The average RNFL thickness and those of the four principal quadrants were analyzed. Appropriate statistical tests were employed. So these are the basic results which showing comparative demographic features of various etiologies. We can see there are broad categories of vascular papillopathy which included diabetic and hypertensive papillopathy, uveitic group, disc edema secondary to retinal vascular occlusion, idiopathic intracranial hypertension, papilledema, AION, demyelinating optic neuropathy, toxic optic neuritis, and compressive optic neuropathy. So there were total 64 eyes, and majority belong to the vascular papillopathy and uveitic group, followed by RVO and IIH group. There was male preponderance in the vascular papillopathy, uveitic, and RVO group. The rest had female preponderance. In the mean age of presentation, we can see that the minimum least age of presentation with the toxic optic neuropathy group and highest mean age of presentation was with the AION group. The vascular papillopathy group, idiopathic intracranial hypertension and papilledema all had bilateral presentation, whereas RVO had unilateral presentation, all of them, and rest of them had either unilateral or bilateral presentation. As regard to the best corrected visual acuity, the idiopathic intracranial hypertension group had the best corrected visual acuity, best presenting visual acuity, whereas the optic neuritis group has the worst presenting visual acuity. And these are the group which shows the initial diagnosis made by the ophthalmologist, neurologist, general physician, or the physician. So this table shows the symptomatology and ophthalmic clinical characteristic in different categories of disc edema. The symptom duration was maximum before presentation was with papilledema and minimum in case of the anti-ischemic optic neuropathy. So these are the different representations of the mild, moderate, and severe disc edema in the various categories and associated fundus features in various categories. So although it's a busy table, the main thing is that there are RNFL thickness in various quadrants. This is inferior, superior, nasal, temporal, and mean RNFL thickness in various subcategories. We can see that the mean RNFL thickness is highest in case of the uveitic group, closely followed by compressive optic neuropathy group. And all of these groups followed the double hump RNFL pattern, that is inferior more than superior and nasal more than temporal in all categories except the uveitic categories.
Sorry to interrupt you, doctor. Your time is up.
So this table shows that the RNFL thickness in all quadrants, so which showed a positive correlation in with respect.
Please conclude.
So our limitation was this has a relatively small sample size and retrospective nature and not age-matched control were taken. So, to conclude, the study provides a baseline demographic profile and RNFL measurements. The clinical severity of disc edema correlated positively with RNFL thickness, and most categories of disc edema followed normative pattern of RNFL thickness despite thickening. And these values may serve as a yardstick for quantitative categorization and may be designed in future studies to validate our initial observations. Thank you.
Thank you, doctor. Do we have any questions?
Yeah, I have one. He has to unshare his screen. Stop sharing the screen.
Yes.
Okay.
Stop sharing the screen. I think I have a question. He has to stop sharing his screen. Yeah, that's it. Ramanu, that's a nice overview of your demographic profile. Obviously, you need more number of patients, but how is this quantification or RNFL thickness alone going to help you in maybe shortlisting what is a causative agent, unless you do other ancillary tests along with it, because disc edema, papilledema, everything will have an increase in RNFL thickness.
Yes, sir. Yes, sir. The main purpose was to see what is the pattern of RNFL swelling and the double hump RNFL pattern that is followed. So as you have pointed out, sir, we cannot say categorically this much of swelling points to this category. So that will not help us, but we wanted to see the pattern of thickening which is present in, but except the compressive and uveitic, which can be explained by the fact that suppose in uveitic group that will be adjacent to the structures involved, retinochoroidal in superior quadrant, so that is expected to involve the superior RNFL thickening.
Yeah, so you have other features like inflammation and all in the uveitis group. Plus, you should do a ganglion cell analysis along with that, because that is usually a more sensitive indicator of things like you had you said with the vision the vision did not recover in patients with optic neuritis. I mean, that why isn't it recovering? Because with modern treatments, usually this doesn't happen. So everything has to be correlated. Otherwise, yeah, obviously go on. I mean, you have when you do more patients, probably you'll have better answers. Nice presentation.
Dr. Samanta, Dr. Vikas here from PJ
Yes,
Lucknow.
Yeah.
You have shown that AIN were 5 cases, na?
Yes, sir.
Arthritic ischemic optic neuropathy.
Yes, sir.
And the age group was 48 plus minus 2.
Yes, sir.
So what were the causes for that AIN? Because usually it should be more than 60. Because
Yes,
can
sir.
you elaborate the causes?
And actually, this is a referral bias also. And as our presenting braining area, majority of the patients had younger age group. So most of the times, the older